biggest psilocybin study in Sweden so far, which aims to treat 100 patients with cancer-related depression. In the talk today, she'll be presenting the background of the study design, as well as how far it's progressed since the start last year. Welcome, Evana.
Thank you. Thank you so much for inviting me here, and thank you all for the perfect foundation for what I'm going to talk about next. My name is Evana López, and I'm a Ph.D. candidate and study physician in the CAPSI trial, which, as presented, is the biggest psilocybin trial in Sweden, so far, at least. I'm in Johan Lundbergs research group, which was also the first research group here in Sweden to conduct a clinical trial called Psychedelic for psilocybin for depression. And during my talk, I will tell you more about the CAPSI trial, why we're doing it, how we're doing it, and trying to answer all the questions that might come up. But then in the end, we'll also have some time for questions too. Starting with the question that we're asking ourselves in CAPSI. If one dose of psilocybin can treat depression in these patients. Today I will talk about the background, why it's so important to try to find a new, efficacious, and fast-acting treatment for these patients. A bit about what we've seen in other trials, but not so much since Ulf touched upon that already. And then coming over to the CAPSI trial. And talking a bit about brain imaging. I'm more in the clinical part of the study, recruiting patients, screening patients, and following up the clinical measures. So I'm not the expert when it comes to brain imaging, but I've got some nice slides from my expert colleagues. So I'll try to present that. Starting with cancer-related depression. This is not obvious for everyone. For some it is, but actually when I've spoken to some oncologists, they say, our patients are not depressed. Maybe it's a question of perspective. I don't know. At least this meta-analysis showed that 40% of all cancer patients during their cancer diagnosis also develop some kind of mental disorder. This can be anxiety, it can be acute crisis, but in many cases it's also depression. Another important part is that there is today no specific antidepressant treatment for these patients. Instead, we use the established treatments that we have today for depression, and these treatments are like cognitive behavioral therapy and SSRIs, selective serotonin reuptake inhibitors. They help many, but not everyone. And they're also associated with some side effects. They can interact with cancer medication. I think that's the, yeah. And they can also take weeks until they have a full effect. And for some patients, they need to try different doses and different SSRIs, for instance, before they find the right treatment. And for this patient group, cancer patients, sometimes they have an ongoing cancer treatment, and sometimes they have so many treatments already that they don't want to try another pill. They don't want to take another pill, which makes the options for antidepressant treatments even less. And also because they sometimes have an ongoing treatment, they have a reduced quality of life already, and they have a lower tolerance to deal with all these side effects that can come with SSRIs, for instance. All of this is some of the reasons why our research group decided to try to find a new and more efficacious treatment for depression in this patient group. This is a picture that I show because the last 6 months, my main focus has been recruitment of patients to the CAPSI trial. And I usually show this picture because some people, they don't know what psilocybin is, and some oncologists, they have never heard about it. And I try, instead of them saying, oh, that's the thing they have in mushrooms, I say it. And then I'm sometimes they have a lot of skepticism, of course. But usually they are quite curious. And I think since this is the truth, psilocybin comes from magic mushrooms, it's better to try to counter that before it's used against us. Anyway, coming back to the last 15, 20 years or so, we have had this kind of renaissance of psilocybin research. And what is all, compared to other antidepressants, what is remarkable with this treatment is that it has fast-acting and also long-lasting effects after one single dose. At least that's what we have seen in previous smaller trials. And as Ulf mentioned, this is too remarkable and too amazing, if it's true, to not do more research on and look more into. We do have some safety aspects that we have to consider, such as the risk of developing psychosis, for instance, if there is such a risk, and how to deal with that risk. There is as Ulf also mentioned, this psychedelic experience that one can have when taking a sufficiently high dose of psilocybin can be experienced as something very difficult. It can also be very meaningful, and it can be life-changing, but it can be involving a lot of anxiety. How do we deal with that? So there are some aspects, and I will come back into that later. But what is also a major thing when I speak to oncologists about this is that there is no drug interaction with ongoing cancer treatment. Psilocybin is active in the brain for a couple of hours, but after 24 hours, there's no psilocybin in the blood. And this is also important when I talk about psilocybin-assisted therapy, that we have these acute effects. They last for 4 to 6 hours. And they can involve all of these emotional, cognitive, and perceptual changes. And somatically, we can see an increase in blood pressure and pulse. But after those 6 hours, the patient or the participant is basically back into normal state. And despite of these, we have these acute effects, but we seem to have also long-term effects on well-being and depressive symptoms. I will come back to that. And this is all the background to why we're conducting CAPSI. And also mentioning, so this is a multi-center trial. I will talk more about that, but we have, it's financed by Vetenskapsrådet and Cancerfonden. So for this trial, all the money comes from there. And saying that if Vetenskapsrådet, that's also a credibility thing. Like when I go around and I speak about CAPSI, just the fact that Vetenskapsrådet stands behind us gives us even more credibility. It is a randomized controlled double-blind phase 2 trial. So this basically means that we have two groups. One with active psilocybin treatment, where the participants receive 25 milligrams of psilocybin. And then we have the other, we have the other group, which is 1/3 of the patients that receive an active placebo, which is a low dose of psilocybin. We are going to recruit in total 100 participants. Today, I will come back to that later, but we have recruited 23 out of these participants, and we started a year ago. So this is like a 1 year, update, we could say, in these regions. So in all these regions, we have the capacity to treat with psilocybin. We have a room, which I will come to in my next slide. We have a decorated room, as decorated as it can be in like a clinical setting at a hospital. And then we have trained therapists. And coming over, I don't know if Ulf mentioned that, but when we talk about psilocybin-assisted therapy, as many of you already know, set and setting is very important. It's never intended, at least not now, we don't know about the future, but at least not now, no one is intending to give a patient a pill or a capsule of psilocybin with them home. Today, the way we treat patients with psilocybin is that we give it to them in Sweden at a psychiatric unit, and they're there during the whole day for treatment. So this is the dosing day, but there's also preparatory sessions before and after integration sessions. And that's, first of all, to prepare the participants for the psychedelic experience that might occur, and also to build alliance and trust with a therapist. So this is about the set and the mindset. And here I have some pictures of the setting. So we really struggle to try to get the cozy vibe. Maybe it's not the coziest you've seen, but it is difficult because hospitals, they have their own. I don't know how many hours I spent on trying to get curtains for Gothenburg. And in the end, I think we had to pay like 12,000 crowns to get curtains, to get fabric into the room. So yeah, the healthcare system is not really built to facilitate psilocybin therapy yet, at least. And yeah, so these are, so the first preparatory session is online, and the second is in this room, to have, for them to get to know the room and also to get to know their therapist. And yeah. Yeah, and also during the actual dosing session, so mostly about the therapy. I didn't do the therapy training because I'm not there during the dosing day. But what I can say about it is that it's ACT based kind of, and it's a bit about mindfulness and trying to. I think that the main thing is like building alliance and trust, but also to try to identify things in the childhood, maybe challenges right now, maybe what their depression or thoughts or anxieties are about right now. And then during the actual day, what they are encouraged to is to go within. They have these blindfolds that they can use if they want to, and they have really selected music for a psychedelic experience. And this music was picked out and put together by some psychedelic music researchers in Denmark. So they are in on this too, and because music has been seen to be very influential in how the trip is experienced. And I will come back to this more later because I've interviewed 9 out of our participants now after 6 months. And then some of them have told me about the music and what they experienced with it, which is quite interesting. A bit about our study design. So we have, in our trial, we have only 1 dosing day. And on this dosing, I didn't show that, but then that's either active placebo, 1 milligram of psilocybin, or it's 25 milligrams of psilocybin. The yellow speaking bubbles are the preparatory sessions before and integration sessions afterwards. And then also, as Ulf mentioned, brain imaging, because we want to try to understand more about the mechanisms of action. And at KI, we have these amazing opportunities to really ask good questions and try to answer them in the best possible way. I will come back to what we're doing during the brain imaging days, but it is full days for at least Uppsala and Stockholm participants. They're there a full day and they have a lot of imaging going on. And this is to try to understand what and how and when and all these things. And actually so this was the base study design, and then we got some extra money. So we were able to add another dosing day for the Stockholm group, which means that we could follow a temporal changes in a bit another way. So there's another brain imaging day on day 7 to 10. So basically 1 week after. Okay, so talking about safety, I mentioned it a bit, but in the exclusion criteria in our study, we have decided not to include patients with bipolar disorder, so neither type 1 or 2, schizophrenia, also hereditary, people that have a first line relative, that is a father or a mother or kids with schizophrenia cannot enter the study. And this is something I need to inform when I speak about this with the oncologists, because there is this fear that psychedelics can cause psychosis among many people, not just patients, but among healthcare personnel too. And the current, so in all the studies, all the trials that I know of, they are excluding schizophrenia patients. And this is because the thought now, and also like what research has shown us yet, is that if a healthy patient or depressed patient that is not does not have schizophrenia, they can experience these psychosis-like symptoms during the dosing day, but it's not a lasting condition. Whereas the idea now is that for people with schizophrenia, or when it runs in the family, it can trigger a latent disease, and that's why we're not including schizophrenia patients. Psilocybin, I think I mentioned it. It increases blood pressure and pulse, and therefore, if the patients have some kind of heart conditions, they cannot enter. There are many more exclusion criteria, but I think this is the main ones to try to ensure a safe environment during the dosing day. We also have some rescue medication that is nitroglycerin to, if the blood pressure goes up, we can lower it, and also some anxiety medications for if the participants have high anxiety. So far in CAPSI we haven't used that, but that is basically how we assess safety. If we use rescue medication and also the report of adverse events. And adverse events can be anything that wasn't there before entering the trial. And this can be, like when I speak to the patients, it's everything that has happened that they didn't have before. So if they fell on the street and they broke their leg, this is a clinical trial, so we have to report that. And so far there has no, I don't know if it's here or next, but at least sometimes, so far there has been no serious, unexpected serious events, and that's something that Läkemedelsverket really want to know and that we have to report on continuously. But I think I got a question about this last time because, for instance, hallucinations, that's reported as a B-effect, as an adverse event, because that's something that, even though we do expect it in the high-dose psilocybin group, it's not anything that was there before. And I think in the one of the biggest psilocybin trials, they reported that half of the participants experienced hallucinations. So if that's a question of not enough, like they didn't report all the hallucinations, or that not everyone in the high dose experienced hallucinations, we don't know. But we have to report on everything. And then coming over to efficacy, how we measure efficacy. And this, of course, we have to, there are many ways of measuring efficacy. And in a trial, we have to decide on the first, like the primary outcome measure. And in CAPSI, this is change in MADRS, which is a validated depression scale that is commonly used in antidepressant trials. This is a scale that consists of 10 different items, measuring everything from appetite, sleep, depressed mood, suicidality, and so therefore it's the total sum of these items that is measured before and then after treatment. And actually in CAPSI we have blinded raters that don't know the participants, and they have these video calls, and they have them at 5 different time points. Once before, and then on day 8, 42, 90, and 180, because we follow them up in 6 months. But our primary outcome measure is day 42. And this is only one of the many, many assessments that we have in CAPSI. I think we measure depression, we measure anxiety, but then we also measure quality of life. We measure also more qualitative things as, and also connected to the cancer treatment and cancer care and other kinds of medications, because this is a very heterogeneous group. Some of the participants, I didn't write that, but they have cancer, but some of them, they have ongoing treatment for the cancer, and some of them, they are ready, they are basically done with all their treatments, but they still have some kind of follow-up with the cancer care. And for some people, oh, thank you, thank you. Do you hear me now better? Yes. Yes, great, thank you. And for some of these patients, they have, they describe, which is very understandable, so their anxiety and depression can really change when it comes to, oh, they have a scanning next week. And then the week after, they have a meeting with a doctor. So before that, their anxiety levels are so high, and then when they get a good, what's it called? Like a good talk with the doctor, and they know, okay, the cancer isn't back, then they feel better again. So this can really change, and we try to follow that in CAPSI too. Okay, so I might come back to that later, but what I want to tell you now is that we have included 23 participants. So actually we had the latest randomization this Thursday. And I have had interviews with 9 of the participants at day 180. And there I have these interviews with them. So we've decided to have interviews with 12 of the participants to try to capture some of the qualitative questions that some of these, many of these assessments can't really capture, because like you said that the assessments, they capture, you have to rate things from 1 to 5. How depressed are you now? 1 to 5. How much has your life changed in these parameters? But then we ask very specific questions, and we try to quantify things, which is important when we try to show effect sizes and that this is an effective treatment, but we can also miss out on things. And especially in this group, so I'm interviewing them about their view on life and death, their view on their cancer disease, their relationship with family and friends, if that has changed, and other things. And what I think, so it's too early for me to present any results today, maybe next year, but probably in 2 years we'll be having all the data. But what I can say is that, at least with the participants that I've spoken with yet so far, they've experienced, it was a nice experience to be in the study, and that's regardless of which group they thought they were randomized into, which is important because we do have all these brain imaging and all these days at the clinic that they have to attend to. But I think there is this general thing that when you're in a trial, you do, in the end, like there's this effect of just being in a trial that can have an effect on your depression. but also that you're being taken care of. People call you, they ask how you are. At least for our participants, that has been experienced as something positive. And what is also very, of course, everyone has their unique psychedelic experience. Some of them, they want to talk about it. And what I can say is that many of them, they tell me that everything else is basically the same. They still have pain. Sometimes they've had surgeries. That means that they can't have sex with their partner anymore, that their life has been changed in ways that they can never go back from. And that remains the same. However, their attitude towards this, their attitude towards the cancer disease, how much they identify with these things, their disease, that has changed. And how that changed, it's different from patient to patient. One told me that she met her deceased father and was able to talk to him. And another one told me that she had this amazing experience, and she had this amazing, she saw her own soul as the most beautiful thing she'd ever seen, was like decorated with like pink and diamonds, and she was like, this is my soul. And then she felt that the cancer was there, but it wasn't her, and she could really feel that. And then later in the trip, also following the music, so she also mentioned that when she could experience these blissful moments, the music was following her, or she was following the music. And then when the music changed, when it became maybe more dark and another tone, the trip itself took a different direction. And at one point she felt like there was darkness coming, and she knew that this was death approaching, and she would meet death. And then she told me that she took off the blindfold, and then she looked at her therapist, who at that point she felt was like a giant bear, like a very, very safe bear. And she looked at him, she's like, things are happening, stay with me. And he was like, yes, I'm here. I'm here. And what he said was, like, they're encouraged to say things like this. And he said, I'm here, practice to just let go. And that was, when she told me about it, that was exactly what she needed to hear. So this was a participant who had a very nice experience. This is, some facts that we'll probably have in our article. This is just until now, but what's interesting to see is that the mean age is about 55, which is not maybe surprising because our patients are cancer patients, so a bit older, but our youngest was 21 and our oldest was 78. And then we need time for question two, so I'll not spend too much time on this. This is something I'd like to speak a bit about. These are other questions that we have in CAPSI, and also we have the economy analysis, like health economy perspective too, that my colleague in Gothenburg will look at. But these are other questions because we're gathering so much data. We could basically spend our whole lives, many lives you can join and analyze this data because we have so much data to answer questions to. And synaptogenesis. So this, at KI, we have this quite new radioligand called SV2A. I should know this, but it's SV2A. No, the radioligand is USBJ, and it binds to SV2A. Just letters and numbers, but basically what it does is that it's a proxy for synaptic density. So the theory is that with this radiotracer, we can measure before and after synaptic density, because that's one of the hypotheses, that psilocybin can change. It can induce neuroplasticity, and this is a way that it has been seen in mice and also in pigs, pig brains. And there are some studies using UCBJ in humans too. And this is a theory that neuroplasticity can come in the form of synaptic density increasing. this is Johan Lundbergs, and he was okay with me using this picture. So this is the other brain modalities that we use in CAPSI. This is our postdoc, Niklas, who's also, so he, together with my other colleague, are the experts in this field. But anyway, what I want to show you with this is that we have super ultra modern equipment at KI, which allows us to ask very advanced questions, and also like to do it in a way that makes sense, not just gather data and then not really knowing what we're going to do with the data. This, for instance, is an auditory oddballs task. So it's easier to analyze data when you have different, instead of just gathering data and having a lot of like brain activity. If you have it together with a task, it's easier to have specific questions and to answer them. So the idea with this is that the participant listens to tones. So it's like do 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 do, and then we image their brain as they do that. And the theory there is that if you are depressed, you are less surprised, and how your brain reacts will be different. This is one of the many things that we do. And then I just want to wrap up a bit, basically saying a bit what Ulf was saying, that there is, so far in the research field, it's too soon to say anything about if, how, and when. Even though that would be very exciting to talk more about and to have specific and concrete answers. Right now, we don't know, but it is important that we continue doing this rigorous research and trying to answer these questions in the best possible way. These are some of the questions that we want to answer, and some of them can be addressed in CAPSI, but with the study design, we cannot answer, for instance, how many doses we need, and if there is a need for a booster dose after 6 months. So, yeah, we know more than we did 20 years ago, and we'll probably know a lot more in 20 years. And I'm so thrilled to be in the field, to be able to follow the development and progress in this field, because so many things are happening. A few years ago, we didn't have this proxy for synaptic density, but now we do, so we can answer the question if that is the mechanism, one mechanism of action. Yes. And then that was it. So if you have any questions.